Welcome back to Tales from the Lab, a veterinary podcast. As you may have noticed, we've made some exciting changes around here. I am your new co-host, Dr. Brad Ryan, Senior Professional Services Veterinarian at Antech Diagnostics.
And I'm Dr. Holly Brown, a clinical pathologist and Chief Veterinary Educator at Antech. Together, we'll be discussing real patients and bring in expert guests to offer deeper insights into the laboratory diagnostics used to solve interesting and challenging cases.
Tales from the Lab is a production of Antech Diagnostics. The intent of this podcast is to provide education and guidance with the understanding that any diagnostic testing and treatment decisions are ultimately at the discretion of the attending veterinarian within the established veterinarian-patient-client relationship.
Hi, everybody. Welcome back to Tales from the Lab. Holly, it's been a minute.
It's been a minute, and I'm grateful to be back.
I know, and we're going to jump into a case, which everybody loves, a good case. And this is Clementine. She is a 9-year-old female spayed cat. She is indoor only, which is an important point that is going to come up here in a minute. But she came in for what everyone thought was a routine wellness visit. But of course, we would not be talking about Clementine if this was a straightforward wellness visit. So, Holly, from your perspective, how often do you see clinically normal patients come in with meaningful lab or abnormalities?
Yeah, and I'm actually glad you even clarified that as meaningful, right? We do see all the time, right? If we look, we find abnormalities, right? There are historical studies that have been done, large data analyses that tell us that in aging pets especially, right, we can expect to find, I think one of the largest studies published as an AHA publication said 1 in 7 adults, 1 in 5 seniors, 2 in 5 geriatrics had not just lab abnormalities that fell outside a reference interval, right? That flagged high or low, but that truly had clinical significance that warranted further workup or intervention.
Right. And so as a professional services veterinarian, we're out there all the time chatting with veterinary technicians, especially about, because they're usually the first ones that are speaking to these owners about, you know, why are you here today? What do you want to get out of this appointment? Right. And so when the owner perceives that that pet is being healthy because they're eating well and they aren't apparently losing weight or acting abnormal in any way, they think everything is fine. And oftentimes the pushback is, I don't think I need to run diagnostics today. But that's what makes this case so important, because this wasn't a sick patient appointment, right? But we did find something, as we're going to share in a minute, that was clinically relevant before she became sick. Yeah. So the other part of this, and I already mentioned, she's an indoor only cat because we hear this all the time, right? I don't need to do a fecal test. She's an indoor only cat, or whatever it may be. I don't need to do heartworm testing. She's an indoor only cat. So Clementine's owner actually questioned whether her indoor only cat really needed that level of testing. You know, we laid out, say we'd like to do a fecal test, heartworm test, FELV, FIV, CBC chemistry, urinalysis, get that minimum database, but she's an indoor only cat. I don't think we need to do that today. But what we want to stress yet again is that indoor only doesn't mean zero risk, because parasites can come in on shoes, insects can enter the home. Heartworm transmission only takes a single mosquito. And from a guideline perspective, routine screening is still recommended, even in those indoor only cats. So Clementine is the perfect example of what we're trying to illustrate here. Without that testing, we would have missed this abnormality that we're about to talk about entirely, right?
Yeah, and these preventive care appointments aren't a one-size-fits-all, right? They are truly conversations, right, where we inform the pet owner about contextualizing the diagnostics and interventions that are most relevant for their pet based on their goals as well, right? Which for the vast majority of our pet owners is, I want to ensure the health of my pet so they live as long as possible, as healthy as possible. And often that means looking for occult or early diseases so that we can intervene earlier to keep them feeling as good as possible.
So we've left everybody in suspense long enough. Holly, tell us what we found when we actually, so we talked this owner into some diagnostics. What did we find?
Right. So her CBC returns first. And on the CBC, we actually do indeed see no significant abnormalities. And we would never just report those results as saying no changes on the CBC, because that truly undervalues the information we did obtain. Normal values also inform us, right? So being able to say, fortunately for Clementine, as she's aging, we are seeing no signs of developing anemia, right, which is commonly seen with a lot of chronic diseases. There's no sign of active inflammation. There's no inflammatory response or superimposed stress response that we commonly see with sick patients. No thrombocytopenias that we may also see. If we get a chance to show them the results, I think we even further show them the value. The CBC is not one test, right? We've looked at all cell lineages and some detailed reports, and happy to report that those all fall within the reference interval and look similar to what we had seen the year previously, right? We gave him more value from this wellness testing when we trended. So no drop in hematocrit, because it may be that it's still within the reference interval, but it's declining, right? But that wasn't the case here. So we celebrated those results. Now on her chemistry profile, things we're taking a close look at. Right, we have an aging cat. We're going to keep a close eye on those kidneys. Right, we saw no elevation of her BUN, creatinine, phosphorus, of renal dysfunction. So that is promising that we report back at. No elevation of liver enzymes. Her proteins look great. But interestingly, a new finding on today's visit was that she had a reported hypercalcemia. So her total calcium came back elevated.
Right, and so this was different than this was an abnormally high value for the first time. The other important point, right, is that we saw a trend from last year. And so that's not something we can ignore, even in an asymptomatic patient, right? A mild elevation might be monitored, but a consistent upward trend, we're thinking something clinically significant is going on here.
Right. Even more concerning. Exactly. And we always do get alarmed, right, as practitioners when we start to see a hypercalcemia because of some of the significant underlying diseases, right, that contribute to these. So this was a very significant finding. We had sent all of this lab work off to Antech Reference Lab. So this was a phone call that the clinician was having with them to review these results. And they talked about coming in for an appointment to follow up on this and some next steps. I will add in the rest of the minimum database, and this is important in how we interpret that hypercalcemia in both its origin and the effect on the body, is that her urinalysis came back. The sediment was unremarkable and pleasantly surprising. Her urine was very well concentrated at 1042, right, her specific gravity. And so for an aging cat, that's an excellent concentration, of course, but also to understand that this was unlikely to be the reason of her hypercalcemia. We don't have evidence for renal dysfunction. And probably even more importantly, at this point, we're not seeing deleterious effects of a chronic hypercalcemia that could contribute to poor renal function.
So let's pause right there, and because this is the moment where clinicians need to organize their thinking, right? So when we see this hypercalcemia, let's think through, or help our listeners think through that list of differentials.
Perfect. And so for a cat, I'll tend to simplify my first approach, right? And so one of my recommendations, because it's easy to remember, is that I will use the mnemonic SHIRT for cats, SHIRT. So S is for spurious. And I like this at the very top of our differentials because there are reasons to get a spuriously elevated total calcium. So before we get concerned, right, and go down a rabbit hole and spend too much money, right, looking for an underlying cause, is to make sure that it's not artifactual. And so if there is, depending on the analyzer that you use, different levels of lipemia or hemolysis or icterus could have an interferent, right, in any of our chemistry reports. And so we want to make sure that that wasn't the case. We were able to see on that Antech report from the reference lab that there was no significant interference noted. If we sent a sample off to the reference lab in a serum separator tube and we did not remove the serum from that separator gel, sometimes if it sits in transit, the calcium in that gel can leach back into the serum and then create this spurious hypercalcemia. This was a lithium heparin sample that had been set in, so no serum separator gel in there. There are other less common causes. If this was a young growing animal, we could have increased bone turnover that could contribute to a hypercalcemia. That was not the case here as well. And ultimately, it is going to be important that we repeat this measurement to confirm that it's not spurious, and that will happen in the rest of her workup. So S is to first make sure that this is not a spurious hypercalcemia. H is for hyperparathyroidism, right? So we know, and we'll talk about a little more in depth, is that the parathyroid gland is what is going to regulate our calcium levels in the body. It's a super important role of that gland. So hyperparathyroidism, if we had a benign or malignant growth on the parathyroid gland such that it's not responding to the fact that the patient's already hypercalcemic and it's still asking for more calcium in the blood, then we could see that hypercalcemia as a result. I for idiopathic, right? And I makes idiopathic differential is so common in so many of our workups. And that can be a little bit frustrating, right? Idiopathic meaning we don't know what is causing it. We've ruled out some of the more significant or more common causes. That's often what leads to a default diagnosis of idiopathic. But I think that in this case, it's important to keep it as a top differential because it is pretty common in cats, far less common in dogs, but pretty common in cats. R is for renal, right? Underlying renal disease. So it is common in our calcium metabolism and how it's handled by the body is that we excrete excess calcium through the urine. And so it would not be uncommon in an aging cat to develop underlying renal disease and renal dysfunction that could lead to a hypercalcemia in the blood. But in this case, as we already mentioned, no azotemia, well-concentrated urine, no signs of renal dysfunction underlying her hypercalcemia. And then T for tumors, right? So that's the one that I think we probably get most concerned about when we see a newly hypercalcemic patient. Again, in an aging cat, we have that concern. Certainly, as we shared our differentials with mom, this was also concerning, right? Underlying neoplasia, most commonly, we think of T-cell lymphomas. We think of, in particular for dogs, anal sac adenocarcinoma. We think of some cats, for some reason, we've seen squamous cell carcinoma, right, as that can contribute, and other less common causes. And the thought is with these tumors is that they make a protein that mimics parathyroid hormones activity in the body. So we get this unregulated production of a protein that's telling the body we need more calcium, and that leads them to become hypercalcemic.
I'm sure everyone's thinking they've been here before. These are complex cases, and so this is obviously where having access to an internal medicine consult line really adds a lot of value to the relationship that they have with Antech, right? Because that we can help structure the approach to these cases, and that's what this particular veterinarian happened to do as well, right, with Clementine.
And I really appreciate their consultations because beyond talking, maybe looking in a book, looking online, Googling this of what the differentials are, is they get to contextualize that conversation specific to Clementine, right? So able to look at her history, her signalment, her other lab work, right, to consult on what are more likely to be the differentials for her specifically, right, and not broadly, so that we can be judicious in our testing that's the subsequent testing and the further diagnostics that they are specifically targeted to Clementine's top differentials, which in this case, given that we ultimately rule out spurious causes, right? We rule out underlying renal disease, that hyperparathyroidism, underlying malignancy, or that old idiopathic all remain as her top 3 differentials after this conversation with the internal medicine specialists.
Right. So Holly, I'm just curious where you've seen things kind of take unnecessary detours when veterinarians jump into diagnostics before they've really refined and fine-tuned that differential list. What have you seen in the past?
Yeah, well, I think the problem is that when we don't feel, as practitioners, when we don't feel confident in our data interpretation, or we don't contextualize it for that case and that priorities of that pet owner, we do a shotgun approach, right? Instead of taking a little time to reflect and go through what are most likely differentials. We've talked about this before in our communication episodes, but sometimes using that value matrix, right? So it's a tool. If we look back in some of our communication episodes, you'll hear us describe, and Dr. Jason Coe describe, using a value matrix, which is to allow around either diagnostics or treatment options. It's a discussion of options with the pet owner, where we can list, what our possible diagnostic opportunities are. Right? We list them, and then usually that's down sort of the left-hand side of a chart. And then across the top, we're talking about what that information would tell us, right? And so what information will we learn from it? How soon will we get answers? Usually how much will this cost, right? The different concerns or values of the pet owner. And so then we can go through each of our diagnostic opportunities. In this case, do we want to do further testing on diving into this calcium, right? Make sure it's repeatable, find out if it's ionized calcium, find out about the hormone levels. Do we want to look into imaging, right? To look for the underlying malignancy. What would that cost? What would that entail? What will that tell us, right? And then we could do, again, we could offer it all, right, to increase our confidence, right, in getting the underlying diagnosis. But I think ultimately the decision is the pet owners, right? And they can't make a good decision unless it's an informed decision. And so I think being able to get our ducks in a row, using the consultation team, leaning on them to help guide our differentials, and then presenting them to the owner with all these other considerations so that they are making an informed decision. And then ultimately, if you actually do bother to fill out this matrix physically, scanning that and having it in the record to show that you've had this conversation and this shared understanding of how the case is going to move forward, it sounds like it would take a lot of time, but you're already having the conversation, right? So instead, what it actually does is just formalizes it. And then once you come to an agreement, you've opened the floodgates to go through the rest of the workup. You're not consistently checking back in with the owner, right?
So we're gonna go through our diagnostic pathway here in just a second. But before we do that, we need to kind of go back to vet school for a second and talk about calcium regulation, because that's fundamental to what we're going to do next, right? So Holly, as a clinical pathologist, I'm going to lean on you here. Because let's walk through how calcium is regulated in the body and why that matters in this case.
Yeah, I mean, so it matters truthfully in every case, right? How our calcium is measured, because that ionized calcium in particular, right? So calcium comes in a few different forms in the body. We have some that's going to be bound to proteins, be albumin bound, which is a significant part of our total calcium. We'll have other bound to other anions that we'll find in the blood as well. But then there's the ionized portion of that total calcium. So most of our chemistry analyzers are going to be measuring a total calcium, which only in part is that ionized calcium. That ionized calcium needs to be very tightly regulated because it's so important for muscle conduction, nerve conduction, muscles like the heart. I mean, these are pretty important things here, right? So the body usually tightly regulates the amount of ionized calcium, and it does that through the activity of the parathyroid gland, right? So the parathyroid gland, when the body needs more ionized calcium, secretes parathyroid hormone, and that has effects on three major tissues in the body, right? So first, the kidneys, where it's going to increase the calcium reabsorption, right? So we don't lose too much through the kidneys, so we can pull that ionized calcium back into the blood. It'll also activate vitamin D3, calcitriol, which will then go to the GI tract to increase calcium absorption through the GI tract. And the parathyroid hormone will also go to bones as a major store of our calcium, right? And increase calcium resorption from bone. So from those three tissues, we're increasing the amount of ionized calcium available in the bloodstream. And then when the parathyroid gland now senses, right, that the calcium levels, the ionized calcium levels are appropriate, there's a negative feedback, right? And it'll decrease its production of parathyroid hormone.
So in a case like this, measuring PTH is really critical.
Is the parathyroid gland functioning appropriately, right? Or is it the parathyroid hyperparathyroidism that's driving, right, her hypercalcemia?
Right. And so in conjunction with that, we need to evaluate the parathyroid glands ideally with ultrasound and also rule out neoplasia that way as well. So some imaging radiographs could be useful. And, most of the clinics that I go into, I would say more often than not, veterinarians are pretty comfortable capturing the images, but they might not always be comfortable interpreting them. So that's where our AIS services really make a huge difference for our practices across the whole of North America.
Yeah, and that was just the case here, right? Because I think when this practitioner went through the differentials with the pet owner, while they started with idiopathic, right, given how common it is in cats, they mentioned the parathyroid gland and hyperparathyroidism because that is the regulator of calcium. But when they got to underlying neoplasia as still one of the top three differentials, that's what sticks always with the owner, right? And so they really went to imaging as one of the first things they did next, is to look, could they detect underlying malignancy? And then, both on thoracic radiographs, which again, as you said, they shared with Antech Imaging Services to get a radiologist opinion, which they did see, some aging changes, but no underlying malignancy, but also did capture some images from abdominal ultrasound, right? And so we're so lucky that we have the opportunity to bring expertise into our practice through these consults, right? So initially in talking to an internal medicine specialist to help guide the differentials and that conversation with the pet owner, but then also for our imaging, because trying to exclude neoplasia is a big step in this. And I think many practices have access to ultrasound, and many of GPs have gotten comfortable performing ultrasound, certainly looking at the major organs, right? But I think being able to have access to a consult, I didn't realize before that you can send your images from ultrasound, both still and looped images, to a radiologist through Antech Imaging Services to get that consultation. And that's, again, what the confidence that this practitioner needed to continue to work up the case in her practice.
All right. And so we have that was performed, and then we have our malignancy profile, of course. So can you remind everybody just the components of that malignancy profile and what each component is telling us?
Perfect, right. So we had effectively ruled out underlying malignancy that was at least visually detectable, right, by sending off for review the radiology, the images, and ultrasound images, and for that lab work that they sent to the reference lab. So again, called the malignancy profile, which is really a bit of a misnomer, but I think it's because ultimately this hormone testing is, no matter what reference lab you send it through, goes to Michigan State, and that's what they call their profile, is the malignancy profile. So that name has carried over to Antech. But in that, what we do is this is really important, and there's special sample handling. So if you are going to be sending off this test, just refer to the guides online or call the lab to make sure you're handling these samples appropriately, especially when you're looking both at hormone testing, but also at ionized levels of calcium in this case. So they had sent off this lab work to get both a confirmation that the total hypercalcemia was repeatable, right? So that's going to be measured in the sample. And of that total calcium, make sure that it wasn't a spurious cause, of course, but of that total calcium, is the ionized component elevated? Because that's the crux of this disease. That's the one that we need to keep the close eye on, right? And so is the ionized calcium. And then from that same timed sample, the ionized calcium comes back high. We need to know that the parathyroid hormone level, is it appropriate in that same time sample, right? So this is why it's sent off as a profile of tests, is to say, is your parathyroid hormone level appropriate for that level of ionized calcium? And then they also will throw in what people will abbreviate PTHRP, which is the parathyroid hormone related protein. They have been able to detect that protein that's secreted by some of these neoplastic cells that mimics parathyroid hormone. They haven't identified it from all malignancies, so not detecting it doesn't mean it's not there. But if it were to be high, if the PTHRP, they found this protein, right, in the blood, there would be worry for underlying malignancy.
Is there anything else that could mean? The PT
HRP? No, otherwise the baseline is 0. Mm-hmm.
Got it. All right. And so let's talk about the results here that we got back on this.
So indeed, the total calcium elevation was confirmed, and unfortunately, the ionized calcium was indeed elevated, right? And why, again, this is so important is because it needs to be tightly regulated in the body. We need enough ionized calcium for appropriate conduction through our muscles, in particular the heart we think of, but also when it's too high, it leads to mineralization or calcifications of our tissues. And in particular, the kidneys seem to take a hit from this most, right? So we do want to keep that well regulated. Catching this at this time while she still has great kidney function is going to be so important, right? It allows us for this earlier intervention to keep those kidneys feeling as good as possible, as long as possible. So on the same sample, with ionized calcium being elevated, we have the PTH level that comes back, right? That parathyroid hormone level, and it is appropriately suppressed. So it is well beneath the reported reference interval of health, and that means the parathyroid gland is acting appropriately. This cat does not have underlying hyperparathyroidism. And for that PTHRP, that protein that some of our neoplastic cells secrete that acts like parathyroid hormone in the body, it was undetected in her sample as well. So that together, right, with her imaging findings, made us feel pretty comfortable that underlying malignancy was ruled out, right? Underlying hyperparathyroidism was excluded. And so she defaults into the ionized calcium being elevated from an idiopathic hypercalcemia.
So we've ruled out our two biggest concerns, but we still have something that needs to be managed. So once we land here, how do you typically manage idiopathic hypercalcemia in cats?
Yeah, well, I wouldn't know as a clinical pathologist, and I'll tell you, this practitioner didn't know either, right? So
I
this
don't know
was
either.
her,
Yeah.
yeah, right. This was her first time working up in a cat,
Yeah.
and so she reached back out to the consultation services, right? So
Perfect.
not only do they have internal medicine specialists, but they have other board certified specialists, including a nutritionist, right? So they were able to help guide, I think, some of our reflex responses. Maybe if you were to Google managing hypercalcemia in cats, would talk about diet changes, but I think there has been some recent research that talk about other supplements that can be used. And again, through these consultants and their expertise, they're able to contextualize the recommendations for Clementine specifically, right, based on the rest of her lab work, the rest of any other clinical concerns. And they keep on top of the research as specialists, right? So we can't do everything as general practitioners in practice, right? And so reaching out and leaning on them to help guide them so that she could go back to the pet owner with, yes, we uncovered some very concerning findings that the ionized calcium is elevated, right, for Clementine. And we are really grateful we caught this early because it will have some irreversible damaging effects on the kidneys if we cannot reduce this level of circulating ionized calcium because of that mineralization. Right now, her kidneys are doing great. We celebrate that, right? The rest of her lab work works great, but we have options for intervening at this stage, right? While she feels well, to keep her feeling as good as possible, as long as possible, and then share the recommendations from the internist and nutritionist.
So let's summarize everything for our audience here. Clementine came in for a routine wellness visit. Her owner thought she was completely healthy. And because diagnostics were performed, this hypercalcemia was identified early before any clinical signs had the owner concerned or the veterinarian concerned. And that ultimately, that finding of hypercalcemia led to consultation, targeted diagnostics, and a structured workup, which ultimately allowed for early intervention, ongoing monitoring. And that's really the takeaway here, right? That preventive diagnostics don't just detect disease, they create opportunities to intervene earlier. And ultimately, that's the goal, right? We're trying to improve the length and the quality of this patient's life. And obviously, I think mission accomplished for Clementine here today. So, Holly, do you have any other takeaways from this case that you want to sort of add here, or?
Yeah, I don't. I mean, I think you summarized it perfectly. I also just saying, we've mentioned this before, as we talk about these preventive care diagnostics, if we uncover, right, occult disease, that's a great opportunity for earlier intervention. And the owner was asking us, is my pet healthy, right? They wanted to know this information. I also think when we don't uncover significant disease, that we also celebrate that, right? That's not a less valuable finding, right? What it does for us is it gives us confirmation, right? And gives us further support for the health that they're currently experiencing. And it gives us more data points, right, that we can use for subsequent trending of lab work for, again, even more earlier and sensitive detection of early disease.
Well, I think this was a very, very important case to highlight for our audience. And for those of you who are listening, we have a lot more coming down the pipeline. So please spread the word about Tales from the Lab. And we will see you next time for another case. Thanks so much for joining us today.
Thanks, Brad.
Listen to new episodes of Tales from the Lab wherever you get your podcasts. And now you can also watch us on YouTube and Spotify.
Be sure to like and subscribe for exciting new content. Share new episodes with your colleagues and follow us on Instagram at Tales from the Lab. That's TAILS from the Lab. We're grateful you're here.